Basics of Medical Biochemistry. First edition, 2023. Chapter 15. Electrolyte Metabolism and Acid-Base Homeostasis. Part 1 of 2. By Professor Dr. Muhammad Jawad. MBBS, DAO, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College Air University, PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. Chapter 15. Electrolyte Metabolism and Acid-Base Homeostasis. 15.1 Introduction. There are three major electrolytes, sodium, Na+, potassium, K+, and chloride, Cl, present in the amounts of about 64, 180 and 74 grams respectively in the body of an adult human. There are many other electrolytes present in different body fluids and doing a significant role in fluid dynamics. These include Ca2+, Mg2+, H+, HCO3, Po43, SO42, NH4+, etc. These electrolytes are essential to maintain normal biochemical reactions and homeostatic functioning of the body. The work of electrolytes is mainly concerned to maintain cell membrane functions, nerve conductivity, muscle contractility, hormonal activity, bone structure, and fluid and acid-base homeostasis. Under normal circumstances, the electrolyte balance is maintained. However, clinical conditions and medications can cause electrolyte disturbances. Sufficient knowledge of electrolytes and their role in fluid dynamics is essential to design a therapeutic plan to manage various electrolyte abnormalities. The concentration of electrolytes is generally measured in terms of milliequivalent/L or mol/L. The equivalent weight, EQ.Wt, of a substance is considered to be the fraction of its gram of formula weight, molecular weight, which could react with or provide 1 mole of hydrogen ion, H+, or 1 mole of hydroxyl ion, O. EQ.Wt of acid equals MOLWT/basicity, number of replaceable H+. EQ.Wt of alkali equals MOLWT/acidity, number of replaceable O. EQ.Wt of salt equals MOLWT/no of cations. EQ.Wt of element or ion equals atomic.Wt/valency. Table 15.1 The atomic weight, molecular weight, and equivalent weight of some important substances. Element or compound. Atomic or molecular weight. Equivalent or valence. Equivalent weight. HCl. 36.5. 36.5/1. 36.5. H2SO4. 98. 98/2. 49. H3PO4. 98. 98/3. 32.66. NaOH. 40. 40/1. 40. NaCl. 58.5. 58.5/1. 58.5. Na2CO3. 106. 106/2. 53. Na+. 23. 23/1. 23. Ca2+. 40. 40/2. 20. The clear concept of equivalence is very important in clinical biochemistry because many of the important solutes in the body are in the form of charged particles. One equivalent is 1 mole of an ionized substance divided by its valency. Molarity, m. It is the number of moles of the solute dissolved per liter of the solution. A molar solution, 1 m, contains 1 gram mole of the solute dissolved in water/solvent and the volume is made up to 1 liter. A millimolar, mm, solution contains 1/1000 of a mole of solute dissolved in the solvent and the volume is made up to 1 liter. Osmolarity and osmolality, 1 gram mole of a non-diffusible and non-ionizable substance equals to 1 osmole. If the substance ionizes into 2 ions, example NaCl into Na plus and Cl ions, then 0.5 gram mole of substance will be equal to 1 osmole. 1 m equals 1 osmole, example glucose. 1/2 m equals 1 osmole, example NaCl. 1/3 m equals 1 osmole, example CaCl2. 1 osmole of a substance is equal to the molecular weight of the substance divided by the number of freely moving particles liberated by that substance in the solution. The osmolarity is the number of osmoles per liter of the solution, while osmolality is the number of osmoles per kilogram of solvent. Osmolarity and osmolality of dilute fluids of the body are the same and may be used for one another. To maintain electrical balance, the total milliequivalent/L of cations must be equal to the total milliequivalent/L of anions in a particular fluid of the body. Table 15.2 Electrolyte content of body fluids. Extracellular fluid/plasma. Cations, milliequivalent/L. Anions, milliequivalent/L. Na plus equals 142. K plus equals 4. Ca2 plus equals 4. Mg2 plus equals 2. Cl equals 103. HCO3 equals 25. Proteinate equals 16. Acid anions equals 5.5. Po43 equals 1.7. So42 equals 0.8. Total equals 152. Total equals 152. Intracellular fluid. Cations, milliequivalent/L. Anions, milliequivalent/L. K plus equals 150. Mg2 plus equals 40. Na plus equals 10. Po43 and So42 equals 150. Proteinate equals 40. HCO3 equals 10. Total equals 200. Total equals 200. Conversion of Mg/dl, Mg per 100 ml, to mol/L. Mg/dl times 10. Atomic weight or molecular weight. Example 1, convert the normal range of serum calcium, 9-11 Mg/dl to mol/L. Atomic weight of calcium equals 40, equivalent weight equals 20 and valency equals 2. 9 times 10. 40. 11 times 10. 40. So, the range of serum calcium in mol/L is 2.25 to 2.75. Conversion of Mg/dl, Mg per 100 ml, to milliequivalent/L. Mg/dl times 10 times valency. Atomic weight or molecular weight. Example 2, convert the normal range of serum calcium, 9-11 Mg/dl to milliequivalent/L. Minimum value equals 9 mg/dl. Mg/dl times 10 times valency. Atomic weight or molecular weight. 9 times 10 times 2. 40. Equals 4.5. Maximum value equals 11 Mg/dl. Mg/dl times 10 times valency. Atomic weight or molecular weight. 11 times 10 times 2. 40. Equals 5.5. So, the range of serum calcium in milliequivalent/L equals 4.5 to 5.5. 15.2 Sodium. Sodium is the principal cation in extracellular fluids as 85 to 90% of all sodium exists here. Its main functions include maintenance of osmotic equilibrium, pH regulation and acid-base balance, regulation of plasma volume, maintenance of cell membrane permeability, regulation of nerve excitability, Significant role in muscle irritability, because of its primary role in the development of the depolarization phase in the action potential. Help in the absorption of glucose in the small intestine via sodium-glucose cotransport. The main food sources of sodium are table salt, salty foods, potato chips, pretzels, etc., baking soda and milk. It is readily absorbed and excreted in the urine and sweat. Aldosterone increases its reabsorption in renal tubules. RDA, recommended dietary allowance or popularly as the recommended daily allowance, of sodium for adults is 1.1 to 3.3 g/day, max limit is 6 g/day. Sodium deficiency may cause dehydration, acidosis, and tissue atrophy. Sodium supplements are usually used to replace sodium and chloride lost through perspiration during high heat. These supplements are available in different strengths as powder and drinks. Sodium excess may lead to edema, hypertonic expansion, and hypertension. The normal range of serum sodium level is 135 to 145 milliequivalent/L or mol/L. Maintenance of sodium balance in the body. One role of the kidney through tubular reabsorption, is the chief regulator of sodium concentration in body fluids. About 2/3 of the filtered sodium is reabsorbed in proximal convoluted tubules. There is a Na plus K plus 2Cl cotransporter operating in thick ascending limbs of the loop of Henle, which is responsible for the reabsorption of 30% of filtered sodium. A fraction of about 5% sodium reabsorption takes place in distal convoluted tubules. Under the influence of aldosterone, reabsorption of Na+ in exchange for H+ and K+ takes place in cortical and medullary collecting ducts. Table 15.3 Serum levels of some important electrolytes. Electrolyte. SI unit. Conventional unit. Sodium. 135 to 145 mol/L. 135 to 145 milliequivalent/L. Potassium. 3.5 to 5.0 mol/L. 3.5 to 5.0 milliequivalent/L. Chloride. 101 to 112 mol/L. 101 to 112 milliequivalent/L. Magnesium. 0.75 to 1.25 mol/L. 1.8-3.0 mg/dl. Phosphate. 0.8 to 1.45 mol/L. 2.5-4.5 mg/dl. Calcium. 2.25 to 2.75 mol/L. 9-11 mg/dl, 4.5 to 5.5 milliequivalent/L. Bicarbonate. 22 to 30 mol/L. 22 to 30 milliequivalent/L. Tubular reabsorption of sodium is significantly decreased in a chronic renal failure resulting in excessive urinary loss of sodium. Loss of sodium in urine is also increased in severe acidosis, as NH3 production is reduced and H+ ions are not buffered. Formation of NH4+ ions is minimal and these are not available for excretion in exchange for sodium. Various conditions of polyuria like diabetes mellitus and diabetes insipidus are also associated with excessive loss of urinary sodium. The use of diuretics such as thiazide or acetazolamide also causes an increase in sodium excretion in urine. 2. Sodium-potassium pump. It is the primary active transport that uses energy from the direct breakdown of ATP. This process is responsible for the maintenance of a high concentration of Na+ and a low concentration of K+ in extracellular fluid. During the operation of this pump, 3 Na+ bind to the carrier protein on the inside of the cell and 2 K+ ions bind to the carrier protein on the outside of the cell membrane. After loading with sodium and potassium, the carrier uses energy obtained from ATP to move 2 K+ ions into the cell and 3 Na+ ions out of the cell. This pump is also known as Na plus K plus AT passe. 3 hormones. following hormones are involved in the regulation of sodium concentration. I. Mineralocorticoids. These are concerned to restrict the loss of sodium in urine, sweat, and saliva. As a consequence of the reabsorption of Na+, water is also retained, so extracellular volume increases and blood volume also increases. Their main examples are aldosterone and corticosterone. These are exclusively synthesized in the zona glomerulosa of the adrenal cortex. Aldosterone also increases the excretion of K+, which may lead to hypokalemia and in severe cases muscle paralysis. 2. ACTH. It stimulates the adrenal cortex to secrete glucocorticoids, mainly cortisol. Cortisol has a weak effect on the kidney to increase Na+ reabsorption and decrease sodium loss in urine. ACTH has little effect on the secretion of aldosterone under normal physiological conditions. However, large doses of ACTH increase aldosterone secretion for a transient period only. 3. Sex hormones. The sex hormones have weak mineralocorticoid activity. They cause sodium retention to some extent. 4. Atrial natriuretic peptide, ANP. It is secreted by cardiac, atrial, muscle fibers. It causes relaxation of smooth muscles, vasodilatation, diuresis, and natriuresis, sodium loss in the urine. It has an inhibitory effect on aldosterone. V. Thyroid hormone. There is an increase in renal blood flow, glomerular filtration rate and tubular transport system, thus helps in sodium excretion. 6. Placental hormones. They increase sodium retention during pregnancy. Hypernatremia. It occurs when the plasma Na+ level is greater than 145 milliequivalent/L. Causes. In most cases of hypernatremia, there is a decrease in free water relative to Na+ concentration. The main causes of hypernatremia include skin burns, hypotonic diarrhea, nephrogenic diabetes insipidus or due to head injury, and iatrogenic, i.e., intake of high-salt foods. There are many endocrine disorders like Cushing's syndrome, adrenal hyperplasia, and Conn syndrome associated with hypernatremia. Conn syndrome, primary hyperaldosteronism, is a condition characterized by increased aldosterone and decreased renin activity, due to certain tumors of the adrenal cortex. There is increased retention of sodium chloride and increased excretion of potassium. Alkalosis results from the loss of H+ ions in urine. In Cushing's syndrome, there is excessive cortisol secretion. Cortisol promotes Na+ and Cl retention from renal tubules. Certain diuretics also cause hypernatremia. In this regard, the drug of choice for diuresis has traditionally been furosemide. However, this drug causes hypernatremia in a significant proportion of patients. Patients with congestive heart failure, renal failure, and hypoproteinemia develop hypernatremia and present secondary aldosteronism. Signs and symptoms. Early symptoms include a strong feeling of thirst, weakness, nausea, and loss of appetite. Symptoms are dependent on the rate of change, level, and volume status. Acute hypernatremia is associated with a rapid decrease in intracellular water content and brain volume caused by an osmotic shift of free water out of the cells. The main symptoms are neuropsychiatric, such as restlessness, hyperreflexia, lethargy, and delirium. In more severe cases there occur seizures and even coma. Hypernatremia is traditionally treated by providing free water supplementation to the patient. Treatment is started with the administration of intravenous 5% dextrose for acute hypernatremia or half normal saline, 0.45% sodium chloride, for chronic hypernatremia if unable to tolerate oral water. Hyponatremia. It occurs when the plasma Na+ level is 135 milliequivalent/L. Causes. Hyponatremia occurs in Addison's disease, a state of hypoaldosteronism due to a deficiency of aldosterone. The main features are hyponatremia, hyperkalemia, acidosis, diarrhea, low blood pressure and decreased heart rate. The defense system of the body is greatly diminished, and finally, hypovolemic shock or cardiac death may occur. Increased secretion of antidiuretic hormone, ADH. causes water retention that produces low plasma sodium. Overhydration, i.e., iatrogenic administration of hypotonic intravenous fluids or excessive intake of water as in psychogenic polydipsia may also produce hyponatremia. Other established causes of hyponatremia include prolonged vomiting, diarrhea and exposure to high external temperature, particularly when salty water is not drunk. Signs and symptoms. The severity of symptoms is concerned with the degree of change and acuteness of change. Hyponatremia slowly shifts the water into intracellular fluid, mainly in brain tissues, and causes cerebral edema. Severe symptoms occur when sodium deficiency is 120 milliequivalent/L. These include various neuropsychiatric problems like lethargy, headache, disorientation, agitation, muscular cramps, and finally seizures and even coma. Treatment of hyponatremia is the administration of salt and aldosterone. 15.3 Potassium, K+. It is the principal cation of intracellular fluid. Its plasma level is 3.5 to 5.0 milliequivalent/L or mol/L, and 98% of body K+ is found within the cells. The concentration of intracellular K+ is 150 mol/L. The main functions of K+ include an important buffer constituent, involved in acid-base balance, participates in water balance, regulates membrane transport. It is essential for the normal functioning of the myocardium, particularly diastole, and also for the functioning of skeletal muscles. Regulates neuromuscular irritability. It has a primary role in the development of the repolarization phase in the action potential. Involved in the activation of many enzymes. Maintains the activity of the Na+K+ pump. The main food sources of K+ are vegetables, fruit, especially banana, citrus, and tomato, whole grains, meat, milk, etc. RDA of potassium for adults is 1.5 to 4.5 g/day. It is readily absorbed in the small intestine, more rapidly than sodium. The absorbed K+ immediately enters the cells under the influence of insulin and catecholamines. Potassium is freely filtered in the glomerular filtrate, but 94% of filtered K+ is reabsorbed mainly in proximal convoluted tubules and to some extent in the ascending limbs of the loop of Henle. About 80% loss of K+ takes place by kidneys through excretion in urine, 20% in feces and a small fraction in sweat. Hyperkalemia. It occurs when the plasma K+ level is greater than 5 milliequivalent/L. Causes. Under normal circumstances, the renal mechanism for excreting the excess of K+ is quite sufficient to prevent possible hyperkalemia, even in excessive intake. The following are the important causes of hyperkalemia. Sudden increased intake. Iatrogenic administration of intravenous K+ may result in hyperkalemia. Injection of K+ should be given with strict care under definite indications with proper monitoring by repeated ECG and serum K+ measurements. 2. Drugs. The use of certain drugs may also produce hyperkalemia. For example, K+ sparing diuretics like spironolactone, Na+K+AT-PAS-A inhibitors like digoxin and muscle relaxants like succinylcholine can produce hyperkalemia. Hyperkalemia may also occur in patients taking inhibitors of angiotensin-converting enzyme inhibitors, as these agents decrease the release of aldosterone. Similarly, angiotensin II receptor blockers produce hyperkalemia by reducing the activity of aldosterone. 3. Cellular destruction. All conditions of cellular destruction like severe tissue trauma, burns, acute and chronic acidosis, tissue necrosis, infected muscles, rhabdomyolysis, intravascular hemolysis, or hematomas. Insulin deficiency, type 1 diabetes mellitus, and hyperglycemia also cause the leakage of intracellular K+ into the extracellular region. 4. Renal failure. Kidney disease is the most common cause of hyperkalemia. Kidneys help control the balance of potassium in the body. In case of failure, they cannot filter extra potassium from the blood or remove it from the body. Pseudohyperkalemia. Falsely elevate serum potassium concentrations may occur as a result of blood sample drawing for laboratory blood tests. It causes the shifting of K+ ions from RBCs to plasma as a consequence of prolonged use of a tourniquet. 6. Fever. High-grade fever is often associated with the liberation of intracellular K+ to plasma. 7. Addison's disease. Main features are hyponatremia, hyperkalemia, acidosis, diarrhea, low blood pressure and decreased heart rate. It is due to a deficiency of aldosterone and ultimately K+ retention because of less urinary excretion of potassium. 8. Metabolic acidosis. The mechanism for hyperkalemia in acidosis is the movement of potassium from cells to extracellular fluid, plasma, in exchange for hydrogen ions. 11. Severe dehydration. The reason is that although the common causes of dehydration, such as profuse sweating, vomiting, and diarrhea, result in a loss of electrolytes, but the loss of water is quite high, so the concentration of potassium in the blood rises. X. Hyperkalemic periodic paralysis. In hyperkalemic periodic paralysis, high levels of potassium in the blood interact with genetically caused abnormalities in potassium channels in muscle cells, resulting in temporary muscle weakness and, when severe, temporary paralysis. Attacks usually last from hours to days. It usually occurs in infancy or early childhood. Signs and symptoms. Hyperkalemia affects the functions of the brain and heart mainly. I. Neurological symptoms. These include fatigue, headache, disorientation, muscular weakness, and paralysis. 2. Cardiac symptoms. Early cardiac symptoms of hyperkalemia are palpitation and chest pain. ECG changes of hyperkalemia include tall, peak T waves with a narrow base, best seen in precordial leads, shortened QT interval and ST segment depression. These changes are typically seen when the serum potassium level is greater than 7 milliequivalent/L. Widened QRS complex is also seen in hyperkalemia. Severe cases of hyperkalemia that are left untreated can lead to fatal cardiac arrhythmias, and cardiac arrest may occur at the diastolic phase. Treatment of hyperkalemia is mainly addressed to remove the underlying cause. Insulin and glucose are given to drive K+ intracellularly. Dehydration and acidosis are corrected by giving the required amount of water and appropriate salt. Protect the possible cardiotoxic effects by intravenous administration of calcium gluconate. Remove excess potassium from the body by sodium polystyrene sulfonate. It is a class of medications called potassium-removing agents. This drug has been a standard part of the treatment of hyperkalemia for decades. Hypokalemia. It occurs when the plasma K+ level is 3.5 milliequivalent/L. Causes. It is very rare that hypokalemia occurs due to dietary deficiency. The following are the possible causes of hypokalemia. I. Excessive urinary loss. Many renal disorders having prolonged diuresis result in hypokalemia. These include the diuretic recovery phase of acute renal failure, chronic pyelonephritis, Fanconi syndrome, genetic defect, etc. Patients taking furosemide and thiazide diuretics for various indications are also at risk to develop hypokalemia. 2. Metabolic alkalosis. It is frequently associated with hypokalemia. 3. Hormones. Excess of aldosterone causes an increased loss of K+ in urine. Excess cortisol and ACTH also have the same effect. 4. Gastrointestinal loss. Hypokalemia occurs in vomiting, diarrhea, gastrointestinal fistulas, after ileostomy, patients taking K+ binding resins and purgatives. V. Drugs. Besides certain diuretics, many other drugs can produce hypokalemia. These include beta-adrenergic agonists, amphotericin B, and alpha-adrenergic antagonists. 7. Excessive shifting of K+ into cells. It occurs in glycogenesis, during treatment of diabetic acidosis by insulin and glucose, familial hypokalemic periodic paralysis, and in excessive production of erythrocytes under the influence of folic acid and vitamin B12. 6. Inadequate intake. It is the rare cause of hypokalemia, and may be seen in starvation, malnutrition, and in those patients who are on parenteral nutrition without potassium. Signs and symptoms. Following signs and symptoms are seen due to the effect of hypokalemia on many systems and organs of the body. I. Cardiac, pathological lesions called myocytolysis to occur in the heart. Rapid and irregular pulse along with low blood pressure. ECG changes are due to delayed ventricular repolarization as flattened T waves, prominent U waves, increase PR interval and widening of the QRS complex. 2. Neuromuscular, lethargy, muscle weakness, rhabdomyolysis, and impaired respiration due to weakness of the diaphragm. 3. GID, anorexia, nausea, and even paralytic ileus. 4. Renal, pathological lesions occur in proximal convoluted tubules of the kidney causing loss of concentrating mechanism that leads to the formation of dilute urine with low potassium. V. Miscellaneous, hypokalemia causes hyperglycemia by inhibiting the secretion of insulin. There may also be polyuria, nocturia and polydipsia. The condition of hypokalemia is managed by treating the underlying cause and administration of potassium supplements. 15.4 Chloride, Cl. It is an essential anion closely connected with sodium in foods, body tissues, fluids, and excretions. It is readily absorbed along with sodium in the gastrointestinal tract. It is excreted mainly in the kidneys, 2% in feces and 4 to 5% in perspiration. It is important for osmotic balance, acid-base balance, and in the formation of gastric HCl. It also maintains tonicity, promotes renal reabsorption of Na+ and helps regulation of acid via a reciprocal relationship with HCO3. Renal acid excretion depends on bicarbonate reabsorption with chloride excretion. The normal range of serum chloride is 101 to 112 milliequivalent/L or mol/L. Hyperchloremia, its common cause is normal saline hyperresuscitation, i.e., intake of too much saline solution in hospitalized patients, such as during surgery or treatment of severe diarrhea. Management is by administration of hypotonic fluid. Hypochloremia, the most common cause of low serum chloride levels is the loss of gastric juice by prolonged vomiting. Hypochloremia leads to a compensatory increase in HCO3 and ultimately results in hypochloremic alkalosis. Hypochloremia also occurs in Cushing's syndrome along with hypokalemia and metabolic alkalosis. Management is by administration of the normal saline solution. Chloride shift. There is a significant role of chloride in the transport of CO2 called chloride shift or Hamburger's phenomena. RBCs produce little CO2 due to a lack of aerobic metabolic pathways. The plasma CO2 diffuses into the RBC, where the following reaction takes place under the influence of enzyme carbonic anhydrase. H2O plus CO2 rightward arrow H2CO3. H2CO3 left right arrow H plus plus HCO3. H plus is trapped and buffered by hemoglobin. The concentration of HCO3 increases, and as a consequence HCO3 diffuses out of the cell in exchange for chloride ions to maintain electrical neutrality, which is termed a chloride shift. Figure 15.1 Mechanism of chloride shift. 15.5 Magnesium, Mg2+. Magnesium is the second most plentiful cation in intracellular fluids. The total amount of magnesium in an adult person is about 24 grams. It is distributed as 50% of the total amount in bone, 45% in muscle and nervous tissue, and 5% in extracellular fluids. The blood plasma magnesium level is 0.75 to 1.25 mol/L, 1.8-3.0 mg/dl. 55% of this plasma magnesium is free, 30% is bound to protein and 15% is bound to phosphate and other anions. Important food sources are all green plants, nuts, whole grains, and meats. RDA of magnesium is 350 mg per day. In pregnancy and lactation its requirement is raised to 450 mg per day. It is absorbed in the small intestine. The major route of its excretion is feces and a small amount is excreted in the urine. Magnesium is an essential nutrient, and its adequate amount in diet is essential for maintaining the physiologic functions of various organs. The following are the main functions of magnesium. Acts as a cofactor of all enzymes involved in phosphate transfer reactions that use ATP and other nucleotide triphosphates, phosphatases, and pyrophosphatases. It maintains the mineral integrity of bones and teeth. Magnesium is crucial in the synthesis and metabolism of parathyroid hormone, PTH, and vitamin D. Magnesium promotes dental health through its antimicrobial nature as well as its ability to reduce oral inflammation. It is necessary for calcium absorption by teeth as well as for the proper functioning of salivary glands. It has a direct depressant effect on skeletal muscle by decreasing the acetylcholine release at the motor end plate, thus used in the treatment of eclamptic seizures. Hypermagnesemia, a serum magnesium concentration greater than 3.0 mg/dl defines hypermagnesemia. Elevated serum magnesium levels are seen in renal failure. Also occurs in patients taking magnesium-rich food or magnesium-containing drugs like antacids or laxatives having MgSO4. All other conditions of cell injury causing immediate shifting of magnesium from the intracellular compartment to the extracellular region also leads to hypermagnesemia. These conditions include soft tissue trauma, burns, hemorrhages, shock, etc. Some endocrine disorders like adrenal hypofunction and hypothyroidism also cause hypermagnesemia. Neonatal hypermagnesemia may result from the placental transfer of magnesium from mothers who have received high-dose magnesium sulfate to prevent premature labor. Most cases of hypermagnesemia are mild and can be managed by decreasing magnesium intake or administering diuretic therapy. Mild hypermagnesemia is tolerated well, but when serum magnesium concentrations exceed 3 mg/dl, neurologic, neuromuscular and cardiac symptoms may appear. Other signs and symptoms include nausea, vomiting, excessive perspiration, flushing, muscular weakness, hypotension and bradycardia. Administration of intravenous calcium is required in severe cases, when cardiac abnormalities are present, to stabilize the cardiac muscle. Hypomagnesemia, it occurs when magnesium concentrations become less than 1.8 mg/dl. Common causes of hypomagnesemia include decreased intake, and excessive renal or gastrointestinal loss, particularly in chronic diarrheas and malabsorption syndrome. Hypomagnesemia occurs in renal disorders like acute tubular necrosis and renal tubular acidosis. It also occurs in hyperaldosteronism and Bartter syndrome, a group of very similar kidney disorders that cause an imbalance of potassium, sodium, chloride, magnesium, and other electrolytes. Many drugs, example tacrolimus, cyclosporin, and aminoglycosides, cause increased loss of magnesium in urine. Hypomagnesemia is common in hospitalized patients receiving magnesium-free intravenous fluids. The hungry bone syndrome is a post-parathyroidectomy condition characterized by rapid, profound, and prolonged hypocalcemia associated with hypophosphatemia and hypomagnesemia. Hypomagnesemia also occurs in diabetes mellitus, pregnancy, and lactation. The main signs and symptoms of hypomagnesemia are apathy, depression, muscle weakness, ataxia, muscle cramps, psychosis, and coma. Cardiac complications include sinus tachycardia and ventricular arrhythmias. Changes in ECG findings include prolongation of conduction and slight ST depression, although these changes are nonspecific. Patients with magnesium deficiency are particularly susceptible to digoxin-related arrhythmia. Management of hypomagnesemia is frequently done by intravenous administration of magnesium. It is because of poor gastrointestinal tolerance of magnesium. Later on, treated cases are maintained on oral supplements. Exercise questions. For MCQ 6 to 10, see Part 2 of this chapter. MCQ 1. A 12-year-old girl was admitted to the hospital with ketoacidosis. Which of the following ions is expected to be reduced in her blood? Ca2+, H+, H2CO3, HCO3. Na+. MCQ2. A neonate baby boy of 1 day old was admitted to NCU for multiple reasons. His ABG report showed pH 7.28, PCO2 78 mmHg and HCO3 29 mol/L. Which of the following acid-base disorders is present in this patient? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. MCQ3. A 28-year-old woman was brought to the hospital for complaints of severe vomiting. During management by intravenous fluid administration, she was overtransfused by normal saline. Which of the following complications may occur in this patient? Hypercalcemia, hyperchloremia, hypocalcemia, hypochloremia. MCQ4. A 30-year-old woman consulted a doctor for complaints of weakness, painful menstrual periods and witching spasms of muscles, particularly around the mouth and hands. A hormonal assay revealed a low PTH level. Which of the following electrolyte imbalance may occur in this patient? Hyperchloremia, hyperphosphatemia, hypochloremia, hypophosphatemia. MCQ5. A 70-year-old man admitted to ICU for the treatment of bone cancer. His ABG report showed pH 7.31, PCO2 43 mmHg and HCO3 16 mol/L. Which of the following acid-base disorders is present in this patient? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. End of Part 1 of 2, of Chapter 15. Thank you.